Welcome to the PathCheck Global Health Innovators talk series. We at PathCheck provide computational health solutions for crowdsourced epidemiology public health solution. Please check our website at pathcheck.org. And if you wish to join our group of dynamic researchers, head over to tiny.cc PathCheck Slack. And if you'd like to see any of the previous talks in this event, please visit tiny.cc/PCF Research Talks. So quickly introducing my incredible co-organizers over here, Ramesh Raskar, Christian Glorioso, Tapratesh Sethe, Nina Resek, and Nise Hudson, without whom we wouldn't have been able to arrange this talk. So thanks a lot for all the hard work that's put in. And I am Rohan Sukumaran, currently a research manager here at PathCheck. So a quick introduction to what the talk series is about. This is a bi-weekly research meetup where we have discussions on digital health, computational health, and how computer softwares or solutions can be used to help augment the clinical practices that is happening right now, particularly in the context of the pandemic. And more importantly, we focus on driving multidisciplinary collaborations through these talk series, where we bring together people from computer science, medicine, bioinformatics, and different other backgrounds as well. So with that, I'd like to welcome both of our speakers today. Thanks a lot for spending this time with us. So we're joined by Shengpu Tang from University of Michigan and Dr. Christopher A. Heinz from Thomas Jefferson University Hospital. So thanks both of you for spending your time with us. And I'll quickly introduce Dr. Christopher over here. Dr. Christopher is an assistant professor of family medicine, geriatric medicine, and physiology at the Thomas Jefferson University in Philadelphia. And Dr. Heinz directs his department's inpatient hospital service, and in 2020 led his department's inpatient response to the COVID-19 pandemic. He's also the author of the 2-volume collection, COVID-19 Essays from the Front, where he documents the pertinent issues of the day while informing his audience on science, medicine, history, and policy behind COVID-19 pandemic. Dr. Heinz weaves this in with his personal account of how his own history and perspective shaped his personal response to the crisis. He lives in Haddonfield, New Jersey, with 3 of his children. So thanks a lot, Dr. Christopher, for spending your time with us, and would love to hear you out.
Excellent. Thank you. It's wonderful to be here. It's such a pleasure. Yeah, I thought I'd give you just a bit of an introduction of how things went in Philadelphia. And I feel like Philadelphia, like the non-New York part of the Northeast during this crisis, has been, kind of steady COVID-19 infection throughout, but never, certainly never the worst in the country, in the United States. So I've, for the past 10 or 15 years, I've switched my practice. I once was an outpatient doctor who saw, all comers, with a little bit of a focus on geriatric medicine. And I really learned to love inpatient medicine. And I've done more and more of that. And I work with a team that includes resident physicians and medical students. And it jives pretty well with my love of teaching. So we have a pretty busy service here. We generally have about 15 to 20 patients at a time. And last March, it became clear to our service, as well as the other hospitalist services in the hospital, that we were going to be facing a crisis of capacity. And we expanded and put together, plans as we saw things developing in New York and in Seattle. We put in plans to expand the capability of the hospital to have beds for COVID-19 patients. We had contingency plans for moving things into parking garages and parking lots, outside academic rooms, et cetera. Fortunately, here in Philadelphia, we never got that bad, but we were ready for them. For my part, we took our hospital service, which had been intact for about 40 years, and we spun off a second COVID-only hospital service. And that's pretty much what I did for about a year, was just take care of patients with COVID-19. And we would have 14 or so patients at a time. And, they were non-ICU patients. So this was the majority of our patients in the hospital, but often requiring interventions that under normal times would land a patient in the ICU. So very high flow oxygen, et cetera. At Jefferson and our academic center here, we have 700 beds in the hospital. Our high water mark for beds was in late April, early May 2020, when about 250 of our beds were patients who were in with COVID-19 illness. We had, of course, the second surge that occurred in the winter, but we never quite reached that level of hospitalization due to really some acquired immunity already in the community, and also some better treatment options, particularly for our sickest patients. And our levels of death per hospitalized patient never reached what they met earlier in the spring. We're dealing with this kind of mini surge right now. We've disbanded our COVID-only teams here. But we're having some cases of patients come in, and I'm sure we'll talk about them. Almost entirely unvaccinated patients at this point, although this morning I just discharged a patient who had been fully vaccinated, but she was medically complex and frail, but she kind of, pushed COVID-19 aside pretty easily. So again, now, like most parts of the country, we're seeing patients who are unvaccinated, but we're certainly not seeing the problems that are occurring in other parts of the country, particularly more southern regions in the US. Along the way, I turned my attention to writing about this. Before I went to medical school, I went to medical school in my late 20s. Before that time, I went to graduate school and got a master's in history. And I worked as a history professor for a couple of years before I went to medical school. In fact, I kept teaching during medical school as a way to keep myself sane. So I've always enjoyed a love of history, and that has morphed into a love of medical history over the years. And in fact, I just been doing some deep diving into the 1918-1919 influenza pandemic, which hit Philadelphia particularly hard, as well as causing 50 to 100 million deaths worldwide. So when this crisis hit, I found that it was probably a useful role for me to try to popularize some of the science. And so I started to put together essays on social media that tried to explain what was going on to lay people, and also give health professionals a place that they could go for reliable information. And over the course of what is now a year and a half, I've probably written about 180 essays that I've put forth. And then last year and this May, I published 2 volumes of a collection of those essays called COVID-19 Essays from the Front. I've been hoping to wrap it all up and put together a large volume containing all of them, but it seems like the goalpost keeps moving as to when we can wrap it up. So I'm still writing them as we go on, but it's been a joyful thing to work on. If we'd like to now, I've been giving a lot of ground rounds lately, talking about lessons that we've learned from COVID-19, and I don't think to this group it's going to be helpful for me to dive into them really deeply, because I don't want to talk to you about things that you already are aware of. But if we want to just go through some of the things that we've pointed out that are things that medical professionals have learned, maybe that will be helpful. So I'm gonna share my screen, if that's okay.
Yep, absolutely.
Yeah. Okay, so this is just a presentation that I've been giving to a number of mostly other physician groups, just talking about if we consolidate and say what have we learned throughout this. I think this gives us a good understanding. And the first thing was that this idea of correcting ventilation perfusion ratios improves outcomes in COVID-19. And just with the lungs, we think about the lungs obviously as being the place where ventilation takes place, and that of course is going to be the exchange of fresh environmental air and the withdrawal of essentially used up air that's expired. But it's important to understand that blood flow is also important in the lungs, and at any given time, half of the heart output is in the lungs, becoming oxygenated at this point. And one of the common pathways to a lot of diseases is a mismatch of this ventilation, which is V, and perfusion, which is Q. And in critically ill patients over time, we've seen that that's been a thing that can be corrected with positioning, with ventilator settings, and so forth. And one of the things that was really remarkable with COVID-19 was this idea that ventilation perfusion ratios were mismatched very early on in sick patients, and that correcting them, again, mostly through positioning patients, made a big difference. And although it's really hard in our business to run good quality studies when we have an intervention like positioning of a patient in the bed that can't be blinded, there were results in anecdotal and in some studies that were imperfect, but have really been remarkable. And it's something that's probably going to change the way that we treat critically ill patients going forward. And this has been something that has been known for years with very, very ill patients. But even run-of-the-mill patients that are coming in for a few days with pneumonia, now non-COVID pneumonia, this is something that we're attempting to take advantage of. So that's really one of the medical lessons that we've learned. A second one is that COVID-19 illness is primarily a disease of inflammation, and this has been a changing understanding over the last year. And so, for example, one of the things that we do to decrease inflammation in medicine is to give corticosteroids, and we give that for a vast number of conditions. I hurt my knee this weekend. I got a corticosteroid injection on Tuesday because it calms down inflammation. We give it for patients with asthma. We give it for patients with lupus. We give it for just a whole host of things where inflammation needs to be controlled, where it has moved into a place where it is detrimental to the patient rather than helpful. And early on, we were very worried about muting that inflammatory response, because with a lot of infectious diseases, and viral infections are a good example, of course, the inflammatory reaction that occurs in response to a foreign particle is an important part of keeping the patient safe. And with many illnesses, keeping down the number of either bacteria or fungi or viral particles is going to be an important part of recovery from disease. So early on, for example, if a patient came in with COVID-19 illness, and I'm talking in spring 2020, we would usually give them steroids if their asthma were acting up. We would really go out of our way to avoid that, because we were worried about muting their inflammatory response that we thought was important to decrease viral replication. And this is a really good example of why medically why we run the studies, and just sitting down and thinking through things often leads us down the road, because it became clear early on that this is really COVID-19 illness is a disease of inflammation. So there's really two peaks to illness, two phases to illness. The first is from the onset of symptoms to about 7 days, where the major problem is viral replication. And the amount that the virus replicates during that time probably has a say in how sick the patient gets. And this is the period in which antiviral medications like remdesivir, which inserts itself into the RNA of the virus to keep it from replicating, can be helpful. But really what we found was that ill patients were dying not in that first 7 days. They were dying, say, 10 to 14 days after the onset of symptoms. And that was because this was the period where the inflammatory response to this foreign particle was flaring up and getting out of control. And we learned early on that far be it from holding steroids, we should be giving patients corticosteroids. And corticosteroids have become an important part of our treatment armamentarium, and probably the most effective thing there is. The cheap generic dexamethasone and prednisone, things that are cost pennies per dose, have really become the most important thing here. And the other thing is we can really predict the patient's response to disease. If anything, COVID-19 disease has been fairly predictable in patients by day. By knowing the day, we can know a lot. So for example, just this morning, an hour ago, I had a patient who came off oxygen yesterday. I knew she was day 14. She was a vaccinated patient, so she had pretty mild illness, but she was 86 years old. But we knew she's not going to get worse at that point because this inflammatory response is cresting at that point, and we would expect her to get better. So this whole idea of this being a disease of inflammation has been something we've learned along the way. A third lesson is that in illnesses that have a high survival rate like COVID-19, it's very difficult to demonstrate treatment efficacy. And, we know that of all comers who get infected with COVID-19, the survival rate is over 99%. Obviously, patients who are sick enough to be admitted to the hospital, that mortality rate is somewhere on the order of 10%. And patients with certain conditions, it would be higher. But when we take all comers, we're talking about a disease that has a relatively high survival rate, about 99%. And we know statistically that interventions to prove an incremental increase in survival are pretty tough. And so many of the arguments that have occurred in society over things like hydroxychloroquine, now ivermectin, and other things have been because it's tough to prove this incremental increase. We need large ends, and we need a relatively a significant increase in survivability. And really the only thing that has given us that so far are steroids. And again, these cheap generic steroids have been the thing that have made a difference. Remdesivir has sat right on the p-value of getting close to proving it a survival advantage. Hasn't quite gotten there, but it does decrease the course of disease. And so we use it regularly. But one of the things we learned is it is very difficult when patients, when we're dealing with a high survival rate to prove that a treatment works. Another thing that we've learned, and I think this has been important to give along to the public, and one thing that I've tried to hammer home over and over again is that viruses have their R naught, which is the reproductive ratio. That is a function of the virus itself, and we can't change that. So, for example, some common viruses that we see, influenza has an R naught of about 1.2, meaning that for every person infected with influenza, in the absence of mitigating measures, we would expect them to infect 1.2 other people. At the beginning of this crisis, the early alpha variants of COVID-19 had an R naught that appears to be about 2.5, and so we can see some geometric spread that it would occur with that. Some other viruses that we see, chickenpox has an R naught of about 8. Measles has an R naught of about 16. So it's incredibly rapid spread. It can spread in a highly vaccinated population if it finds essentially crevices and coves where there are enough non-vaccinated persons. And this new Delta variant has an R naught that looks like it's about 8. So we're dealing with a level of infectivity that we saw with chickenpox. And again, it's important for people to know that we can't change that. That's a function of the virus itself, but the effective reproductive rate, the RE, we are able to change through measures like social distancing and masking and limiting indoor contact. The interesting thing that we face now, and I imagine we'll get questions about this, are with a viral variant now, and I really do believe that we need to treat this as a completely different disease now because of the infectivity. Do those measures that before brought down the RE to levels where you're going to have viral decay over time, are they going to be effective in bringing it down? So in other words, are masking and social distancing really going to make a difference with a virus with an R naught of 8, or is it vaccination, natural immunity, or nothing? And obviously that's something that's going to be seen. Another lesson that we learned quite a bit is that asymptomatic and pre-symptomatic are very different concepts. And I've been, it's been difficult to see these terms bannered around in the media interchangeably, and they really are different. Viruses have evolved in order to spread during pre-symptomatic periods. That's going to aid in their ultimate Darwinian goal, which is going to be just to propagate the genetic material. Most patients who are referred to as asymptomatic when there is spread are actually pre-symptomatic, meaning Most patients here develop symptoms. Most patients who are going to develop symptoms 5 to 7 days after exposure. Asymptomatic spread, while possible, remains pretty unusual. And again, we can only tell the difference between asymptomatic and pre-symptomatic retrospectively. But if we do good retrospective studies, it appears that most spread is in that pre-symptomatic phase in patients who are eventually going to develop symptoms. And what we've seen in the literature, even with the new Delta variants, is that it remains to be true. There are not many asymptomatic individuals who are spreading disease. There are certainly asymptomatic infections, but essentially the viral load that exists in the respiratory epithelium is not high enough to transmit that disease. Again, that's probably a little different with a virus that has an R0 of 8, but overall, these are different concepts, and we want to be very careful about which we call out. Kind of related to that was the 6th point that I'd like to talk about, is that vaccines only need to drop the effective reproductive ratio below 1.0. And I think, one of the lessons I've taken from this is that we focus, and this is a very American thing to do, is we focus on the efficacy of vaccines as they apply to the individual. In other words, the individual makes their assessment of risks and benefits, and obviously the information that gets to them is often adulterated. We know that very well. And then they make the decision regarding the vaccine. And I have found myself writing to vaccine hesitant people and saying you need to look at the risks and the benefits, and that only tells part of the story. Really, there are 2 other components to that I think we miss out on. The first is the ability of the vaccine not to stop disease or infection, but to stop severe disease and death. And that really needs to be a focus here. And, since March, there have been about 120,000 deaths in the United States from COVID-19. So since that time that vaccines became at least, widely available among vulnerable populations, only 1,200 patients who have died of COVID-19 have been fully vaccinated. And so 99% of the deaths that we've had have been in unvaccinated folks. And that is really what I think we need to be hammering from a public health point of view, rather than the adage that you're protected from getting infected there. The other thing is important, and again, I know this goes against our stubborn American individualism, is this idea that vaccines don't need to be perfect. They just need to drop that effective reproductive ratio below 1, because when they do that, there's going to be decay that occurs, exponential decay in viral replication, and it's going to disappear. And we've seen that happen in the Northeast. We've seen that happen in other parts of the country. We are getting disease now because this more infectious variant is finding pockets of unvaccinated people. And also, when you have an R0, we know that the number of people needing to be immune to have herd immunity is going to increase over time. So maybe we're being outrun by the virus here. But again, I think this public health message is really important. And then the last one, which when I wrote it, I thought we were done, but historically viral pandemics proceed in waves, and they have. And the 1918, 1919 influenza pandemic had at least 3 major spikes, and then had multiple regional spikes, including a very large one that led to thousands of deaths in New York City in 1920. And of course, the difference there was they didn't have the ability to have a vaccine to stop further spread and increase herd immunity. But we do, but we're seeing further waves at this time. So those are some of the lessons that we've worked on at this point, that I think we've gathered at this point. And I'd love to take questions and have a discussion about anything you guys would like to.
Thank you so much. This is so awesome. When you were talking, you had like 5 million questions. There's so much going on at this time, I think, with all of this. But we do have one more speaker. Do you have time to stick around for that, and we can do questions at the end, kind of integrate?
Absolutely, okay. Yes, and
I'm
interested in hearing.
Perfect, thanks. I'll let Rohan introduce our next speaker.
Yeah, sure. So Yeah, thanks again, Dr. Christopher, for that wonderful talk. And with that, I'd like to welcome Shenku Tang from University of Michigan to speak next. So Shenku is a PhD candidate in the Computer Science Department of the University of Michigan, Ann Arbor. He's a member of the Machine Learning for Data-Driven Decisions research group led by Professor Jenna Wentz. His research focuses fundamentally on developing and applying machine learning methods to help solve important problems related to healthcare. While motivated by specific use cases such as risk stratification and dynamic treatments recommendation for various diseases and medical conditions, his work aims to identify interesting technical challenges and propose novel solutions that are broadly relevant to the fundamental AI/ML research. In the past, he has also contributed towards reinforcement learning, deep learning, time series, sequential modeling, transfer learning, causality, algorithmic fairness, and much more. So with that, I'd like to welcome you to carry on with the presentation, Shenku, and thanks for giving this talk here.
Yeah, thank you, Rohan, for the introduction. Let me start sharing my screen. All right, are you able to see the screen?
Yeah, we can see.
Yes, thank you so much. And thanks for inviting me to speak to you all today. My name is Shenku Tang, and I'm a PhD candidate in computer science and engineering at the University of Michigan. Today, I would like to share my work on reinforcement learning with set-valued policies, which is a framework that I'm particularly excited about that lays the foundation for clinician-in-the-loop decision-making using AI and machine learning. So let's jump right in. In hospitals today, we're collecting an immense amount of data about our patients. Machine learning techniques can be used to discover patterns in these data, with which we can improve care for future patients. In a supervised learning setup, one typically focuses on predicting some diagnosis or outcome, for example, whether the patient will survive or the probability of survival. While this information might be useful, it is not necessarily immediately actionable. Beyond diagnosis, high-quality patient care means delivering the right treatment to the right patient at the right time. In addition to knowing who's unlikely to survive, we can use machine learning to help clinicians select the best sequence of treatments in order to improve patient outcome, like survival. We consider a reinforcement learning setup. At each time step t, the agent perceives the state st, selects an action at, and receives some reward before transitioning into the next state. This cycle continues for every time step. Here, the overall goal is to identify the policy or a mapping from state to action that maximizes total reward over time. In our setting, this corresponds to selecting the best treatment based on patient's health state, which may be different vital sign measurements. Applying a policy to a patient corresponds to a trajectory that involves a sequence of treatments. Note that the action I take now impacts not only the immediate reward, but also the next state, and thus all future states and possible future rewards. A key challenge of applying RL in healthcare is the reward. What reward should we optimize for? Should we optimize for long-term quality of life or short-term stabilization or vitals? What if I'm willing to undergo an invasive treatment over taking a drug that might have severe negative side effects? Designing a single reward function that captures the goals and objectives across different patients is challenging. While there has been some work on augmenting rewards via reward shaping, oftentimes researchers in healthcare will default to a reward based on survival, since it represents a clear goal and is easy to quantify from data. However, using survival as the reward is likely to induce near equivalent actions. For example, different doses of a drug might perform similarly in terms of keeping the patient alive. If we simply apply the standard RL framework and learn the single best action, we will end up ignoring these near equivalencies. In reality, there could be many actions that lead to a similar outcome with respect to survival, but they differ due to a variety of factors not accounted for in the reward. It remains challenging to define a universal reward that captures goals of different individuals at the time of training. Not to mention, the goals of an individual could change. Recognizing the challenges, we seek to learn policies that incorporate near equivalent actions. We formalize this notion as the set value policy. Instead of mapping from each state to a single best action, we learn a mapping from each state to a set of near equivalent actions. Let's consider an analogy. Here, in the frozen lake environment, we want to get from the initial state S to the goal state G without falling into the lake through the black cells. Instead of identifying the single best route, a set value policy maps each state to multiple near equivalent actions, thereby finding multiple routes to navigate the world. Putting things into the healthcare context, at each time step, the learning agent recommends a set of actions to the clinical care team, who then selects among those actions for the final action to take. This allows for interaction between clinicians and the decision support system, and gives the clinicians in the loop an opportunity to incorporate individualized aspects of rewards that are difficult to quantify. Despite the potential appeal of this framework, there has been relatively limited work on learning set value policy. Most notably, Fard and Pino proposed a solution for finite horizon planning, but requires knowledge of the MDP model and an exhaustive search over all state action pairs. In light of these limitations, we propose a new algorithm for learning near optimal set value policies that applies in model-free settings and can be solved efficiently. While learning near equivalent actions might seem straightforward, the sequential nature of decision-making in RL makes it more challenging. Recall that the choice of actions impacts not only the immediate reward, but also the next state and possible future rewards. For two actions to be considered near equivalent, not only should they be similar in the short term, meaning they have similar instantaneous rewards, they should also be similar in the long term and lead to similar futures. Before we formalize the notion of near equivalency, let's first recall how we define value functions in an RL setting. Assuming we always act optimally, pi star, we can recursively define the value function of a state action pair, or the Q value, as the expected instantaneous reward, plus the value of taking the best action in the subsequent state as prime. From this, we can define the value of a state with respect to an optimal policy pi star as the Q value associated with the best action. However, in our setting, remember that a policy maps each state to a set of actions instead of a single best action. Thus, the notion of value must account for all possible downstream choices. So we consider a worst-case analysis, where V pi is defined as the minimum Q value over the actions in the recommended set, pi s. Here, the policy gives us a set of actions that we believe are near equivalent, and this assumes we select the worst amongst those. Again, Q is defined recursively, only now it is the immediate reward plus a worst-case future. To quantify how good our set value policy pi is compared to the optimal policy, in line with past work, we define near optimality using a multiplicative constraint. Assuming V star is non-negative, a user can specify zeta, the suboptimality margin. As we increase zeta from 0 to 1, we trade off optimality for more choices in our set of actions. So if zeta is 0, we default to the optimal action. And as we increase zeta, we'll get larger and larger action sets. Given the zeta, our goal is to learn a set value policy that satisfies near optimality. There's a trivial solution, however, where for each state, we only recommend the optimal action. This policy satisfies the constraint, but this is not very useful and doesn't add anything to standard RL. Remember, our goal is to identify near equivalent actions and provide choices when possible. Here's the key idea of our approach in a nutshell, the near greedy heuristic, which says a near optimal set value policy should be near greedy with respect to its Q function. You can think of this as a near greedy action selection with respect to the worst case Q value of pi. Using this equation, we can derive a family of value-based algorithms for learning set value policies. Specifically, we'd examine a temporal difference variant based on Q learning. Here's the algorithm on one slide. Like Q learning, we iteratively update our estimated Q values by sampling transitions from the environment. But we replace the greedy action selection in the Q learning update with our near greedy heuristic. Just like Q learning, this algorithm is off policy and does not require the MDP model. But unlike Q-learning, this algorithm is not guaranteed to converge in the general case. It's possible that no solution exists depending on the MDP dynamics and the optimal value function. However, in our ICML paper, we showed that the algorithm is guaranteed to converge to the unique solution for directed acyclic graphs with non-negative rewards. Though the theoretical results only hold for DAG environments, I want to spend the remainder of this talk demonstrating the algorithm's behavior in a more general setting of a non-DAG problem. Specifically, we consider the task of learning to treat patients with sepsis. We use data from MIMIC and a problem setup similar to past work, where the state space is derived from 48 physiological signals measured at 4-hour intervals. And there are 25 discrete actions corresponding to 5 levels of vasopressors and 5 levels of intravenous fluids. We ran our algorithm on this data set with the suboptimality margin, zeta, set to 0.05. To investigate the applicability of our approach, we looked at what our algorithm identified as near equivalent. We visualized the action near equivalencies in this 5x5 grid. On the horizontal axis are 5 levels of vasopressors, and on the vertical axis are 5 levels of IV fluids. Each cell is a combination of the 2 interventions and corresponds to one of the 2 discrete actions. Within each cell, we'll plot a small 5x5 heat map to indicate how often every other action is considered near equivalent to the action of that cell. So let's start by interpreting a small slice. Specifically, what actions are considered near equivalent to using no vasopressors and a small amount of IV fluids? We see that the action itself is always included in the near equivalent set. And about 35% of the time, using no IV fluids is considered near equivalent. And we see this distribution for larger doses of IV fluids, which makes clinical sense. Here's the overall picture of the result. To further interpret these results, I would like to introduce Dr. Schoding, our clinical collaborator, who's a critical care physician at Michigan Medicine. He's going to tell you more about these results. And let me make sure my audio is working. I think so. Okay.
Results of this figure are consistent with what I would expect based on my clinical expertise. So first, take a look at the column first from the left. So these actions correspond to when fluids are administered, but no vasopressors are administered. And you can see vertical bands in each cell, which means that similar doses of IV fluids without vasopressor treatment are frequently considered near equivalent. And this corresponds to what I would expect physiologically, that when patients are given similar doses of a medication, we would expect them to respond in a similar manner. Also, if you look at the second row from the bottom, which corresponds to a low dose of fluids and a range of doses of vasopressor, these actions are also considered near equivalent. Finally, the top right cell may seem a little inconsistent with some of the other results. And it suggests that when the action is to administer a very high dose of both fluids and vasopressors, a near equivalent action may be to do nothing or give no treatment. So this may seem counterintuitive, but it's actually also consistent with my clinical experience. In some very sick patients, no matter what we do, they end up having a similar bad outcome. And that's largely because at the time we're able to treat them, their disease has already become irreversible. So overall, on the clinical task of learning near equivalent sepsis treatments, I think our proposed algorithm is able to uncover clinically meaningful actions that are near equivalent.
So to summarize, in this presentation, I introduced our work where we proposed a new algorithm for learning set value policies that provide action choices while maintaining near optimality. However, we have to remember that the algorithm is only half of the picture. Once we algorithmically derive the set value policy, it is also important to conduct user studies with the clinicians in the loop to understand whether our recommendations of action sets make sense and are helpful. We also have ongoing work applying this framework to learning treatments for respiratory distress, which has potential applications for management of COVID patients. You can find more details by scanning this QR code or visit our GitHub repository. I would like to acknowledge my co-authors, Aditya Modi, another computer science PhD candidate at Michigan, Dr. Michael Schoding, who's a critical care physician at Michigan Medicine, and my advisor, Professor Jenna Weeks. Thanks for listening, and that's the end of the presentation.
That's great. Thanks a lot, Shanku. That was a really good talk, and I think there are definitely a lot of questions out there.
Yeah, I'm happy to take any questions, and together with Dr. Haynes.
Awesome. So I guess for anyone in the audience, if they want to ask a question, I can either use a Q&A feature or on the chat. And if any of the panelists has, feel free to unmute and ask the question. So while I'm collecting questions from the audience, maybe Christian, you could start with the questions, if you.
Yeah. So I didn't realize how well these two talks went together. This is a little bit of an accident, but a really happy one. So I think, I have a bunch of questions individually, but I think just kind of like starting the discussion between the two of you would be really cool. So, so I think I'll start with Dr. Haynes. Have you seen any of these machine learning algorithms in your practice, and what are people saying about, using algorithms to come up with treatment strategies that like maybe are novel or new insights, or, deciding between things?
I mean, first of all, I found that fascinating, and algorithmic care has certainly become something that is accepted and used, and almost certainly to the benefit of patients. I see the end results of this good research, and I've had very little insight to how this is come up with, and that's why I enjoyed watching that so much. I mean, this is something we need. I mean, I was thinking as you gave that presentation is how arbitrary sometimes the amount of IV fluids we give very sick patients can be, and having that data is really helpful.
Very, very cool. So in the hospital, you're seeing sometimes people using these algorithms at some points. Is it being used clinically at all, or is it kind of too new?
I mean, I usually have very little knowledge of how they're generated, but we have treatment algorithms that we use, for example, for congestive heart failure. Certainly diabetes, when somebody comes in with diabetic ketoacidosis and we're titrating an insulin drip based on various inputs, it's done algorithmically. I worked on our algorithm 10 years ago for that, and I must say it was a lot more trial and error than actually good data being punched into databases like I just heard about. So that's lovely to see.
Very cool. And so do you have questions, Shanku, for Dr. Haynes in terms of like COVID-19 and algorithms, and where do you see this going?
So at my institution, we actually have ongoing work that's developing not this treatment recommendation paradigm, but more on the traditional supervised learning, predictive diagnostic paradigm, where we're trying to predict deterioration of COVID-19 patients. Do you think that kind of tool will be helpful in terms of managing the, like for example, the strain on the hospital resources? If we can like identify who's unlikely to deteriorate or who's more likely to deteriorate.
Yeah, and it is something we're using, but really in a rather slipshod manner. So we're measuring things like C-reactive protein and D-dimer on these patients, and building databases. And I know there are folks at our hospital that are working in an inter-hospital group that I think includes Mayo. I'm not sure about Michigan, but to try to predict clinical outcome before we can see changes in vital signs or subjective complaints on the part of the patient. At the beginning, we tested 12 or 15 different laboratory values on these patients regularly, and we've narrowed that down as it has seemed that only a few have predictive value. But yeah, I mean, a way to collect that data and to be able to understand a day or two before we see clinical deterioration. This is, as I mentioned, this is really a two-humped camel-like curve that we see with patients where they They face a reckoning around day 10 of illness, and they go in one direction or the other. They either they go home or they get more sick. And predicting who those patients are is incredibly difficult. And a model that attempts to do that through, and I would imagine it would be inflammatory markers like we just discussed, would be wildly helpful and help us, with a little more certainty, send patients home, which that is really where hospital resources become significant. Because if I can, instead of watching someone for a couple more days because I have a feeling in my gut, if I can point to literature that says, here's your D-dimer, here's your CRP, this is what's going to happen, boy, that would be incredibly helpful.
Absolutely. And Shunku, in terms of the data sets you have, so what kind of data sets are you using? Are there big sepsis data sets? And are you able to see is there a way to sort of do a clinical trial to see whether these machine learning is having would have better outcomes than some of the decisions clinicians are making? This is like some of the questions I was just stewing about, so feel free to answer any of that or some of it.
Yeah, no problem. So just to give more details, we use the Mimic3 dataset, which is from, Ron just chatted, but Mimic3 dataset is a large-scale ICU dataset collected from the Beth Israel Deaconess Medical Center from, I think it was from 2008 to 2012, or even before that. Yeah, so it is I think it's a widely recognized data set for electronic health record data. But in terms of what actually can we take away from these treatment recommendation policies that are algorithmically derived, I think we have to be careful because there's a fundamental difference in the paradigm between the supervised learning, where we're just predicting the outcome, versus reinforcement learning, where we are trying to improve the outcome. Because for supervised learning, from the historical data, we know that when the patient exhibits these vital signs and these lab values, we see their outcome. But when we think of the reinforcement learning, where we're changing the treatments to the patients, we actually don't see the outcome. Like, we don't actually observe what could have happened if we changed our policy. So it's actually a really interesting technical challenge and a really difficult one. And I think that's what my future research in the next about 2 years will be focusing on, is how can we reliably estimate this new policy that I derived algorithmically. Can we say anything concrete about its effectiveness? And if we're for example, can we say that our policy is definitely better than the clinician's policy that's currently being used? And with that certainty, then I think that will be some evidence for us to continue this research into the more involved clinical trial stage. Yeah.
So you cannot know making a different decision, right, in this reinforcement learning model. So if you could you somehow bin the data into, is there enough granularity in the data to bin it into different potential outcomes and kind of match the patients and look to see which patients did better?
Yeah, I think that's actually one way you could do it, is to stratify patients based on outcome and see whether your policy will do better in a particular subgroup of patients that have different severities.
Yeah.
Mm-hmm.
Sure.
But I think fundamentally it is limited by the fact that the data is based on past observations that relies on what treatments the clinicians actually took. And if we recall the sequential aspects of the decision making, if I made this treatment, then the patient's state has changed. And maybe the next treatment that I wanted to, the clinician administer, is no longer available at that time point. So it's really hard to, how can we use historical data and still be able to join those different pieces together in order to say, if I apply this new policy, I will get this trajectory of the patient. If that makes sense.
Definitely.
Right. So while we're on this, I just had a quick question on this. Since you're introducing a clinician in the loop solution, and you mentioned that the rewards are sort of given by the clinician to see like how well the model is performing. So how do you sort of get this at every time step, or do you have it at the end of an episode or after several episodes? When is actually the clinician's feedback looped in?
Yeah, very good question. I think in the presentation, I didn't mention explicitly how we define the reward. So there are, even though we have multiple time steps, there are no intermediate rewards. The reward is only assigned at the terminal time step, where the patient is either survived and discharged or the patient has died.
Oh, I see. So it's sort of like a binary reward at the end,
Mhm.
end of the final, the treatment once the
Yes,
treatment.
that's correct.
I see.
But the important point for reinforcement learning is that all of the action that I took will actually the final reward, you can attribute the final reward to any time step. Like any of the actions you take could have contributed to that final reward.
Right. So sort of like the discounted reward policy.
Mm-hmm. So it's important to take into account how much attribution of the final reward do I attribute to my action at this time step.
Right. And as you mentioned in your later slides, that this could potentially be used for COVID patients, or so do you see that? Do you see the system as a way to identify, let's say, this patient is going to have severe lung damage, so we should do X, Y, Z, or we should make sure that a ventilator is available. Things on that. Which exact direction, or which are the directions that you're looking at for specifically in terms of COVID?
Yeah, so in terms of COVID, or more specifically, we are looking at patients with acute dyspnea. So patients who present to the emergency department with shortness of breath, which is a wider population where we have previous data from 2015 to 2019. So specifically, we're looking at interventions such as mechanical ventilation, heated high flow nasal cannula, and IV vasopressors, fluids, and diuretics, steroids, and anticoagulants. So a multitude of different treatment options. And we're trying to identify whether some of these are near equivalent, because as we know, when there is a shortage of ventilators, these treatments are not available. So what are some of the close to equivalent choices that we can give to patients, but still keeping them alive? That's the general setting that we're working on there.
I see. Wow, that's super interesting. Yeah, I think that's really important and could have a lot of impact as well. So that's really nice. So I had another question with this for Dr. Christopher. So as you had mentioned through your presentation, that we're seeing the disease, people with vaccination also getting admitted to disease, and there's a whole discourse happening on the internet where people are doing probability of vaccinated given infected, probability of infected given vaccinated, and telling that no, this is happening. 75% of the people are vaccinated. So would you like to sort of give our audience a clear thing on what should be the metric that we should look at, and what are you seeing on the ground when people are vaccinated? How different is it?
Sure. The real metric we should be looking at is mortality. I think that's, obviously the most important thing. And we're at I always like to tell people when I talk about drinking coffee with them is that we're in an incredibly large randomized study where half of the population drinks coffee and half doesn't, and nobody's ever found anything that's wrong with drinking coffee. So it's very unlikely. Well, we're about at that situation now nationwide. We have 167 million people who are vaccinated, about the same number who are not at this point. And if we look at deaths since March have been about 99% people who are not fully vaccinated. So, as we can manipulate that number to talk about effectiveness and other things that have various levels of meaning. But really the most important thing is that, you're really, again, that's been a moving target of what percentage have been vaccinated through the months, but you're really about, if one is going to die, 99% of likelihood is that they were not vaccinated at this point. Hospitalizations are a a higher number. And I alluded to, I just discharged someone this morning who was fully vaccinated with an mRNA vaccine in March. And she was very ill, and she's 86 years old, but she was just sick enough to be hospitalized. And so just required about 2 liters of supplemental oxygen, peaked, discharged on day 15 of illness, day 2 or 3 of hospitalization, did really well. So, is she a hospitalization? Yes. But we're seeing, probably upwards of 90% of hospitalizations in the Northeast are non-vaccinated individuals. And we know that the majority of people are vaccinated, which makes that number even more impressive. But I think it's really important that we are honest and understand that there's no perfection in these vaccines, and that a number of patients are going to be hospitalized. And then finally, as far as infection goes, infection with mild disease or disease not warranting hospitalization, that percentage of vaccinated individuals who get that is even higher than the 10% of the share of folks who are hospitalized, who are vaccinated. So again, I don't think anyone ever said this was going to be perfect in stopping the spread of the virus. This probably has a lot to do with the antibodies that are important in stopping invasive disease versus the type of antibodies that are important in the surface, IgA, that are minimally affected by vaccination. But really, our big take-home message should be that death has decreased markedly.
Yeah, and then are you guys at this point, are you sequencing for Delta or other variants? Do you have an idea of whether the breakthrough cases you're seeing are Delta?
We presume they're all Delta. So a few weeks ago, Delta got to 86% nationwide, and it has, in true Darwinian fashion, it is conquered, and the original COVID, we presume, is not there. There's a certain percentage that gets sequenced. It's small, but that's run by the CDC. But we're not routinely sequencing patients. We're presuming it's Delta, with strong reason to do so.
Mm-hmm. Yeah, the reason I ask is because that has been a particular challenge for people modeling during this thing is sort of not enough data. There's not enough data about what variants are, and linking variants to breakthrough cases to type of vaccine. So we're, as modelers, having a bit of a hard time. It's making our job more difficult because the data doesn't exist.
Yes.
So especially with Delta, because I'm thinking about Delta, and I think it totally makes sense. Yes, almost all the cases are Delta at this point, right, in the US. But if there's a new variant that starts to pop up, or if Delta has different mutations, because there's
right.
Delta, and then there's Delta Plus and Delta Plus Plus, and so Delta is not all the same thing. They're not the same mutations. So I wonder about this. Seems to me, and maybe you can speak to this, and maybe it's my misunderstanding, but there's like a little bit of a disconnect between like what the utility of what hospitals are doing and what modelers want. So like in Pittsburgh at UPMC, one of my good friends is an ER doc, and he was saying that they were even not allowing them to test for COVID for a while if someone had it 3 months prior. They were assuming that even people that were immunocompromised, which could very well have, not developed immunity the first time they got it, right? So I'm just wondering where this disconnect is coming from between modeling and hospital testing.
I personally, I think we've under-resourced sequencing in this country, and we know about Delta because of the work that was done in the UK and India. And we've piggybacked on that. So as far as seeing, a Delta Plus or another variant develop, I think we're doing some sentinel testing, but certainly not widespread, which, again, clinically, it doesn't make a large difference, for modeling makes a very large one. And particularly if you're dealing with variants that have widely different R naughts, that are going to determine spread. So yeah, it's been a strange place to get cheap all of a sudden. We've done very little with sequencing.
Yeah, it does strike me as odd. Like maybe there's just, because I think, going to med school, if it doesn't change clinical management, why run the test? You learn this, right? Like, so I get it from that point of view, but then I think sort of this like understanding how it helps us predict things better, and especially with boosters, because when I think about vaccine boosters, you know, they're going to have to include the correct mutations, right? And so if there's like knowing which mutations are in Delta versus Delta plus plus, and which one is worse, and what the actual mutation is to design the new vaccine boosters. So yeah, have you seen much with boosters coming down the pike? Because I know there's been a big debate about third shots and, you know, new shots.
I heard this morning they're coming. I heard that this morning the CDC is going to recommend for some subset of immunocompromised individuals a booster shot. How they're going to define that, what I'm hearing is going to be very loosely. So it's not going to be you have to be on chemo or a monoclonal antibody. It's going to be you consider yourself immunosuppressed. So that could be somebody with diabetes. That could be, you know, any of the more common conditions that may lead to increased prevalence. But they're apparently the FDA or the CDC is going to recommend that in the next few days.
Oh, very cool. That's great news. So I've also heard there was a paper out recently about post-exposure prophylaxis. Have you heard about this? Giving people vaccine boosters as if they've been exposed to COVID-19, they're immunocompromised. The FDA has now approved them to get almost like if you're exposed to HIV and you can get, you know, PrEP for.
I haven't heard that. No, that's an interesting approach. So.
Yeah. Is there any? I know you talked a lot about drugs for inflammation being front runners. Is there anything else that you've sort of heard about that might be interesting new drug candidates coming down the pike? Or
just a recurrent role for Ptosazolamab, which is a monoclonal antibody IL-6 inhibitor that is finding, you know, we were using fairly routinely last spring of 2020, then really showed no benefit for patients that were on the floors or even in the ICU, but in the very sick patients in the ICU who seem to be worsening rather despite maximal treatment, there is a role for that. Otherwise, the monoclonal antibodies given to the outpatients have been really disappointing. Giving them for patients who are admitted is really disappointing. We're really just still with remdesivir and with dexamethasone or other steroids.
Cool. And are you seeing? So they're all over the news, right? And we're seeing this. Have you seen an uptick in children at all in the hospital? Is that happening in Philadelphia?
We're having a few more admissions. I don't know if it's significant at this point. You know, there were really none at Children's Hospital of Philadelphia since the very beginning. I don't believe their ICU is full right now. I don't believe it's been very significant. You know, certainly other parts of the country, they're filling pediatric ICU beds. And we don't know whether that's due to this being a more virulent strain, or whether it's just a matter of more infections. A certain percentage of those will go poorly.
Yeah. You also mentioned ivermectin and hydroxychloroquine. And so an interesting thing is we've been working a lot with people in India, and there is an online pharmaceutical company there called Tata 1mg, which only exists in India. And some of the top medications have been hydroxychloroquine, ivermectin, and antibiotics, which could be problematic for antibiotic resistance. Do you have thoughts on this in terms of like these medications and how bad it is to have doctors prescribing these kind of things to patients?
I mean, I gave hundreds of doses of hydrochloroquine at the beginning when that was what we were giving, and the evidence wasn't clear. In retrospect, maybe we just wanted to do something to help, and there wasn't anything at the time. The evidence is really clear for hydroxychloroquine that there's not an incremental benefit from it. It is a pretty safe drug, fortunately. does have some cardiac toxicity that's pretty rare, but it's something that people, with lupus can take for a long period of time without experiencing ill effects. But in the long run, the benefit is essentially zero. And so the risk is, albeit small, outweighs that benefit. Ivermectin, I haven't looked much into the literature. Again, it's really safe. I mean, it's a drug that you'll give to little children for intestinal worms. It's pretty safe. Again, it's really difficult to prove an advantage. And anecdotes, I know are the bane of all of your existence. And somebody who says, I think there's a video going around online now where a guy at a school board meeting says, I gave 15 patients a cocktail of hydroxychloroquine, ivermectin, and I think vitamin D, and none of them went to the hospital. Well, anybody I gave 15 patients that got COVID-19, a statistical sample, the average would be none of them go to the hospital, whether I give them Coca-Cola or placebo or whatever. So none of them have that advantage. And so fortunately, they're relatively safe medications. Azithromycin is not. Azithromycin has fraught with side effects. So fortunately, that doesn't seem to be the one that people are given inappropriately. But again, it speaks to the problem of a really high survival condition. One can argue very easily and be a shill and argue that it's their interventions making a difference when it's not.
Right. So I actually had a quick question for Shenpo. So this is more along since you're more on the machine learning or reinforcement learning side of things. And what are the major challenges that you've seen? I read through that you've also worked with COVID and other health-related issues as well. So what are the major challenges that you see when we sort of, as non-medical people, non-medical experts, sort of step into this and try to interpret results, build models? Like, what are the major challenges that you have come across?
Well, the first thing, which is related to what Christian has mentioned, is the data problem. Because at the beginning of the pandemic, so like it was March 2020 where, or more like May 2020, where we started trying to build a model to predict COVID patients' deterioration, right? At that point in time, we didn't have much data for COVID patients. So instead of using those patients' data to train the model, we actually use them for evaluation. And we leveraged the past 5 years of data from patients with related illnesses as the training data to derive our model. So I think that's like an interesting challenge, but also like a workaround solution, which is transfer learning. But on that point, like as we're seeing the new Delta variant, it's unclear, at least to me, like right now, how well our model would generalize to those new patients with Delta variant. So I think that highly depends on like how much different their clinical, how they exhibit clinically, and how the clinicians, like the clinical treatment strategies differ for those as well. I guess another important point is that the machine learning and AI tools are not to replace clinicians in this process. They're to augment the clinicians when there's a resource shortage or staff shortage to help them make better decisions. Yeah. And that's all I wanted to say. Yeah,
I guess it makes a lot of sense, especially with, as you picked the example of Delta, we're seeing that there is a change in the symptoms that people were experiencing. At least in earlier models, what we were, even from our group when we were modeling, we were seeing like lack of taste, lack of smell. They were seen as like top features or like top predictors of COVID-19, speaking from the modeling parlance. But now it seems like that might not be the case, and the infection period or the inception period is like cut short, much shorter. And so yeah, I guess whether we could make use of transfer learning to the ever-changing dynamics of the virus sounds like an interesting and tough problem as well.
Yeah, and on top of that, another important question is, if let's say I built a model and it works well at Michigan, we don't want to repeat this, or like we don't necessarily want every hospital to repeat this process to like build their own model and that doesn't seem very scalable, and we don't necessarily have that much expertise at every place, especially for those small community hospitals. So it's really important that if we can identify features that transfer not only across time, but also across space, so that the model could also generalize to other hospitals and other institutions, and to like future diseases if those are related closely enough.
Right. So a three-dimensional transfer, like time, space, and across diseases. Yes, that looks pretty interesting as well. And yeah, I guess that's somewhere where like data interoperability and how we could bring in privacy preserved solutions where different hospitals like across maybe from the US and India could collaborate in. Because specifically, even if we look at the case of COVID, we were seeing like there was a huge difference when what things happened in India. Like in the second wave, like we were having different types. Like it was all something very new to us. Like people were getting newer symptoms or like newer consequences, so like black fungus, white fungus. Like it was all over the news, and yes, fake news. Let's not go there yet. So yeah, I guess this is pretty important for like. This is where like we all should sort of work together, clinicians, healthcare workers, and us data scientists as well. So yeah, and definitely much more other from fields, other fields as well. Right.
Yeah, I think I mean, that it is true that the symptoms of Delta are a little different, which I think it is a big problem for machine learning, right? Because you train on a data set and you're testing on what is now a different data set entirely because Delta looks so different, right? And like loss of smell and anosmia is dropped down to the 9th most important symptom. And now, the symptoms that are popping out are more like cold symptoms, right? People now have runny noses and more GI symptoms. So if you're predicting COVID with these symptoms that used to be the top symptoms, they're no longer true for Delta, right? It's a moving target in a sense that way.
Yeah, so I think for data scientists and machine learning, you need at least some amount of data to work with in order to be able to infer the future, what's going to happen for future patients, right? But with that small amount of data, I think we should be able to identify the features or the symptoms that are relevant, that persist, that transfers, and then we can use that. Yeah, but it's still important to have some data and some clinician input even with like the new variants, for example. Yeah.
Right. So I guess just like high level, how do you think that we can collaborate better? I guess I'll throw this out to both or either of you. Collaborate better between computational people to best serve the needs of clinicians, and also to have the resources that computational people need to provide those models and those kind of things to clinicians.
I mean, I think regional based models on prevalence of disease and how that translates into hospitalization is really important and allows us to, moving forward with, inevitable future pandemics, allows us to allocate hospital resources. That is the biggest need. So this is how much is present. And I know that data is really difficult because the availability of testing has varied so much throughout this that, making a link between the prevalence of the illness in the population and the amount that are going to be sick enough to be hospitalized is difficult, but some up-to-date or best fit that can explain that to hospitals would be really valuable.
Yeah, I think like in general, I think to do this kind of research requires an interdisciplinary team consisting of both the computer scientists and the clinicians, and maybe more people in the middle that bridges the gap. And I guess one other point of from a more technical perspective of how to communicate better with our machine learning findings to the clinicians is the interpretability aspects of the models, or explainability. How can we explain what the model thinks to the clinicians? And those are also exciting directions for research.
I mean, definitely this sort of just translation between the two worlds for sure. So how did you develop the relationship with the physician you're working with, and what is that like? Is he driving the ideas, or are you guys coming to him and saying, would this be useful? Like, what is that relationship like?
Oh, so actually, I think so. I met the clinical collaborator through my advisor, who Professor Jenna Wings, who I believe they met at a conference, which focuses on machine learning for healthcare. Yeah, and I believe at Michigan there are also other like more interdisciplinary research centers that tries to bridge the gap between clinicians and computer science researchers, and also IOE, like industrial and operations engineering, and a lot of that as well.
Very, very cool. So did he come to you guys and say, hey, we would like better ideas about sepsis, like what to do with sepsis? Or was it you guys coming to him and saying, we have the sepsis data set that we're working on, can you help us explain it? Like, yeah.
I think it's more like a two-pronged or two-sided process, where the sepsis is a long-standing problem for clinicians and also for machine learning. And we have this interesting idea of trying to learn set value policies. And we know that he's an expert in like ICU and sepsis. So we reach out to him, but he already knows a lot about the problem itself. And I believe there's also ongoing work trying to develop better sepsis models, sepsis prediction models as well.
Very cool. So is that gonna be part of the University of Michigan sepsis management, or what are the practical implications at where you guys are?
Oh, so for this one, it is, I don't think we're at that stage yet. As I mentioned, there are still technical challenges in terms of how can we quantify the improvement or even qualitatively evaluate the policies that we recommend. So we haven't reached that point yet, but I imagine if we are able to come up with a solid evidence for that, our policy is significantly better than the current clinical practice, then I think there should be a pipeline or a framework that allows us to integrate those to the clinicians' EHR system dashboards or something like that. And before clinicians are actually going to see the results, I think there also needs to be rigorous validation, like randomized clinical trial things, where some clinicians are presented with this decision support tool while others are not. And then we can see during that validation process to see whether this really helps.
Sounds amazing. Yeah.
So that, I guess we've overshot the time again. So and I think we have almost covered all the questions. So okay, all right. So thanks a lot, Shampoo and Dr. Christopher, for spending this long time with us, and much more than the time that we had asked for. So thanks a lot for doing that. And I'm sure everyone found this discussion very insightful and engaging. And we look forward to working with both of you and collaborating further as well. And yeah, discussing more on this direction. So once again, thanks a lot for coming and spending this time with us.
Thank you so much.
Yeah, thank you.
Thank you so much.